Thank you for inviting me to the second edition of the conference. I think I was privileged enough to be here last year as well. Last year, I spoke about root canals and jawbone vision, and today I'm going to speak about biologically advanced endodontic procedures. In next 30 to 45 minutes, I'll try to highlight which biologically advanced procedures now we're introducing into endodontics and how much clinically relevant they are in today's time. As I've been introduced, I belong to country named India. This is my state called Gujarat. I'm professor at Karnataka University in Gujarat. By profession, I'm an endodontist. My keen passion is also for digital dentistry, and that's the direction in which I work. I also have three different clinical practices in my city. And this is going to be the content for today. So today, when I'm going to talk about biologically advanced procedure, in other words, it is more about regenerative endodontics. I always feel and believe that endodontics is a science which is very much less appreciated by current generation. Due to the wave of implantology and more company-driven dentistry, people, particularly dentists, are losing their charm of saving the teeth. And that's where we are pushing the science of endodontics. When I talk about endodontics, there are mainly three different endodontic treatments around which our endodontic world revolves. The first is conventional endodontic treatment, when our tooth is infected by caries, trauma, or there is some periapical disease. As a last resort to save the tooth, we have to clean the pulp chamber, we have to clean the contents of the pulpal tissue, and that is called primary root canal treatment. When our primary root canal treatment fail, we have option of secondary root canal treatment, which is also known as retreatment, which is a non-surgical, and at the same time, we can opt for the surgical option when there is an cystic involvement present in the periapical area. Now, millions of teeth are being saved all across the world by root canal therapy. Through the current modalities, there is definitely high success rate. But are they ideal treatment? What we are doing in today's dentistry is that we are removing the pulpal tissue and we are shaping the root canals. At the same time, we are placing artificial materials like gutta percha into the root canal system. Now, the biologically driven approach is a regenerative approach where we try to create and deliver the tissues which can replace the missing pulp or the damaged pulp or the diseased pulpal tissue. And this concept is now gaining more attention since last decade in the dentistry. The whole regenerative dentistry has been tried since last 15 years, but the more success ratio is now being achieved due to increase in awareness of the technology, and at the same time, due to more involvement of the clinicians on the research side, new materials have been developed and which are more biocompatible, which are giving us much more predictable outcomes. So here, what are we going to talk about? When we say biologically driven endodontic approach in a root canal treatment, that means we want to create a tissue which can simulate dental pulp, which can have some innovation, which can have some vascularity, and at the same time, it help patient to retain the tooth intraorally with all the functionality. So regenerative procedures are biologically based procedures which are designed to replace damaged diseased structures, particularly dentine and root structures, and as well as the cells of the pulp dentine complex. There's another terminology being used in endodontics which is called tissue engineering, which is an interdisciplinary field which applies to the principle of engineering and life sciences, where we develop biological substitutes which restore, maintain, and improve tissue function. Stem cell form the essential part of this entire treatment. Now, stem cells are the clonogenic cells which are capable of both the self-renewal and multilinear differentiation. And stem cell differentiation is the only factor on which we rely when it comes to regenerative dentistry or regenerative endodontics. When we want stem cells to proliferate or differentiate, we want some signaling molecules, which are preferably proteins. We want scaffold, which is a three-dimension biological tissue which create environment which allow cell growth, proliferation, differentiation, and adhesion. On your screen, you can see 5 different stages of tooth development. So in our undergraduate studies, we are usually taught that when a crown of the tooth has been formed completely, the root completion will take another 3 to 4 years. From A, B, C, D, and E, what you can see from A to D is immature apex, and E is having matured apex. Currently, when we are meeting in 2023 December, most of the regenerative endodontic treatments are focused on the immature teeth. So whenever we are having teeth which are having incomplete root and formation, these are the prime candidate who can be opted for biologically driven endodontic procedures. Though there are many studies which have opted the same approach for the mature teeth, but still more predictable outcomes have not been achieved. So what are the main objectives that we are looking at? When we are going for regenerative endodontics, our main objective is to regenerate a pulp-like tissue. Ideally, pulp-dentin complex, but most of the time it is not exactly pulpal tissue, it is more of a combination of dentin and cementum type of tissues. We also want to regenerate the damaged coronal dentin. At the same time, we want to increase the root end length or the root end thickness. So if we are dealing with the immature apex, we appreciate if the root end development takes place over a period of next 2 years following the treatment. And that shows us the positive outcome of the treatment. So the primary goal is elimination of any symptoms of the patient, and evidence of the bony healing has to be achieved. The secondary goal is increasing the root wall thickness and preferably increase root length. But the tertiary goal, which is the most difficult one to achieve, is positive response to vitality testing. That means we expect some vascularity in a new developed root end. And that is a tertiary goal which is very difficult to achieve, and scientists and clinicians are still trying to chase that. So what is the biologic base for this entire regenerative endodontic therapy? Now, historically, long-term calcium hydroxide treatment has been used for apexification treatment. But the success rate has been reported as high as 95%, but still there are many problems with this conventional treatment. The main treatment, if I want to highlight, number one, it forms a fragile blunderbuss canal. There are more chances where tooth fracture cases have been seen. There have been cases of canal obliteration which have been observed. It makes tooth brittle, so it has reduced proteolytic properties. The barrier which is formed is porous and it is not continuous. This treatment may take up to 3 months to 24 months and multiple visits. So as you can see, it is already having many limitations. And what we define as a successful treatment, it can take a follow-up up to next 5 years, which is a very long goal. Now, when we talk from endodontist perspective, we only look at success and failure with the terms of effective and ineffective. We say that our treatment is effective if there's elimination of symptoms, there's bony healing, there's root closure within first 12 months of the treatment. And if there is still persistent periapical lesion, then we call it ineffective endodontic treatment. So as I was talking about the change in material science, the evolution of material science has led us to development of more biocompatible material, more bioactive material. And one of the most bioactive material which is used in endodontics, which is called panacea for endodontists, is MTA. So mineral trioxide aggregate is a substance which we are using over calcium hydroxide for cases of apexification, for cases of regenerative endodontics, for perforation repair, for any barrier formation, because the success rate is high and at the same time, it creates a barrier on which even new cell formation and attachment are possible and feasible, and last 8 to 10 year studies have really concretely established MTA as very essential material when it comes to regenerative endodontics. So what you can see on your screen right now, the first radiograph is showing open apex. Whenever there is open apex, now we are going for apexification, where we are creating artificial barrier with MTA in the apical end. And we expect a complete root formation even around it with the follow-up of 12 months, 24 months, 36 months. So it provides better long-term prognosis. Now, there are a few counter arguments as well that sometimes the pulp generation can lead to some discoloration of the teeth. It can also lead that it is not essential for the form and function aesthetic of the tooth. But we can always say with all the literature and the studies that following the root canal filling versus the tooth restoration found that the root canal therapy prolonged tooth survival and the removal of the pulp in a compromised tooth may still lead to tooth loss in comparison with the teeth with normal tissue. So it is essential to undergo root canal treatment. And when we are undergoing root canal treatment in a teeth having necrosed pulpal tissue, we have two options now. Either we can go for the traditional approach or we can go for the regenerative approach. When we are going for traditional approach, we can have mature or immature teeth. We can go for conventional root canal treatment. But today we are talking about the regenerative approach, where we are opting for the approach called revascularization. We can look for the pulp implantation. We can look at the treatment where we have revascularization by blood clot formation. Even gene therapy has also been tried and tested. We'll talk about all these approaches of regenerative endodontics one by one, but before that, it is very important to understand that which triad is playing very important role in this entire science. So there are three key elements. The first of them are cells, which are stem cells. Second are signaling molecules, and third one are called scaffold. So stem cells is a very important factor when we want proliferation of a similar type of tissue. Growth factors are the signaling molecules which stimulate stem cell to proliferate and direct it to the particular differentiation. And scaffold provide environment on which the stem cells can be affected and grown by the growth factors. Stem cells, theoretically, it is a undifferentiated cell of multicellular organism, which is capable of giving rise to indefinitely more cells of the same type, and from which certain type of cells can be created. When we talk about dentistry in a human body, particularly around the tooth, there are multiple types of stem cells which are being generated. The most commonly used stem cells are derived from the deciduous teeth. So they are called SHED, stem cells from the human exfoliated deciduous tooth. Apart from that, there are multiple epithelial cells which are used. Adult mesenchymal cells have also been tried. Adult hematopoietic stem cells have also been derived. Out of all the stem cells, for us, it is very important to use allogenic stem cell. So, and apart from that, what we are using in today's dentistry are the autologous stem cell. We are not dependent on any other person for the stem cell. We are using patient's own stem cell for the growth of the pulp-like tissue. Stem cells have also been classified as totipotent, pluripotent, and multipotent cells. And as the name itself suggests, when we are dealing with the dental patient, all we are dependent on are the multipotent stem cells. The postnatal stem cells have been saved by preservation of umbilicus cord, but till date, its clinical approach and the clinical usage is very limited. It has not been cracked yet. So as you can see on your screen, the multiple type of stem cells, particularly the stem cells from the human exfoliated deciduous tooth, adult dental pulp stem cells from the apical papilla, which are called scap, stem cells from the dental follicle, stem cells from the periodontal ligament, and stem cells from the bone marrow. Out of all the stem cells, clinically relevant two most important stem cells are the stem cells from the apical papilla and the stem cells from the human exfoliated deciduous tooth. They've been vastly used in majority of the dental studies. Now, it is important to understand that these stem cells are autologous. They can only give you proper results if they get proper exposure to the growth factor and proper scaffold. Before we go to that, on your screen, what you can see are the dental pulp stem cells. They have striking ability to regenerate pulp-like tissues. At the same time, they are very difficult to isolate. They are very difficult to derive. Stem cells from human exfoliated deciduous teeth, they are easy to save, easy to be preserved, easy to get. They have higher proliferation rate than the stem cells from the permanent teeth. They can be retrieved, which is a disposable. They are readily accessible. Ideally, they are suited for the young patient when they are at the mixed dentition stage. Stem cell from the apical papilla was first isolated in 2008 by Sonoyama. It is essential for the root development, and they are capable of forming odontoblast-like cells which produce dentine in vivo. As you can see over here, where actually these cells are lying, they're lying at the end of the apex, and that's why we call them apical papilla stem cells. So when I talk about revascularization, these are the stem cells which are going to be useful. Periodontal ligament stem cells, as the name itself suggests, that derived from the periodontium. They were first isolated in 2004, but they have not been of much use, particularly for development of the pulp-like tissue. A pig model has been tried, they have been tried in different animals, but the success rate has not been so high. Now, with the transcription factor OCT3 and SOX2, some induced pluripotent cells have also been derived. But with the stem cell, the biggest challenge lies in identification of the stem cell, isolation of the stem cell, and storage of the stem cell. And this is something which is done by the microbiologist. As a clinician, we are mainly dependent on the autologous stem cells, which are definitely we can use directly intraorally. There are two strategies which are used for the dentin regeneration with bone morphogenic protein. The one is in vivo therapy, where they are directly applied to the exposed pulp or directly applied to the amputated pulp. And second is the ex vivo therapy, which consists of isolation of the DPCs, where we have the direct pulp stem cells, the differentiation with recombinant BMP or BMP genes, and finally the autogenous transplantation is done to regenerate the dentine. That was all about the stem cell. Now jumping to the scaffold, so it provides a three-dimensional structure or a mesh on which stem cells can get growth factor, they can proliferate. They should allow cell attachment and migration. They can deliver and retain cell and biochemical agent. They can provide structural support. They can provide nutritional support as well to the stem cells. So these are the ideal requirements, what you can see on the screen. They should be biocompatible. They should have adequate strength. Most importantly, they should be biodegradable. Many types of scaffolds have been used in dentistry, but what we usually prefer are the biological scaffold. So collagen has been widely used as a biological scaffold. Along with it, glycosaminoglycan has also been tried and attempted. It has good biocompatibility and bioactivity. It is easy to place, allow placement of the natural tissues after undergoing degradation. But the only disadvantage is that cells in collagen matrices undergo marked contraction, and that can affect the pulp tissue regeneration. I'm sure all of you must have heard about PRP and PRF, platelet-rich plasma and platelet-rich fibrin. These are forming different type of scaffolds which can allow the growth of stem cells. Growth factors which are released by the platelet, like fibroblast growth factor, transforming growth factor beta, insulin growth factor, keratinocyte growth factor, epidermal growth factor, vascular endothelial growth factor, and platelet-derived growth factor. All these growth factors can reach to the stem cell if they have been placed properly in the scaffold. And then we can have PRF, which provides ideal scaffold. It does not dissolve quickly after the application, but it is slowly remodeled in a similar way to the natural blood clot. These days in endodontics, we are not only using PRF in the non-surgical procedure, but even after endodontic surgery. For the guided tissue regeneration, now we are using PRF on day-to-day basis. That was about natural scaffold. But at the same time, we can also use some artificial scaffolds, particularly the polymers, which can lead to polylactic acid, polyglycolic acid, and polygalactic glycolic acid. So which is PLA, PGA, or PLGA. These are the synthetic hydrogels, a synthetic material which can provide artificial scaffold. This artificial scaffold are slightly expensive. So most of the clinicians in the developing countries these days are preferring more of a natural scaffold like collagen. Now, this particular scaffold what we are talking about, they should have good biocompatibility. They should undergo auto-degradation. And that's why the pore size is also very important. Now, how to create and use this tissue construct is something that we need to learn. In this era of technology, first we take CBCT of the patient. At the same time, clinically, we harvest cell from the patient or harvest cell in terms of a donor. Then, as I mentioned earlier, it is all about identification of the stem cell, isolation of the stem cell, and storage of the stem cell. And after that, there is delivery of the stem cell along with the growth factor. We have to implant this construct into the donor site. Another approach is non-cell-based approach, which has been tried and tested. The defect is very small, but it is not proven to be effective. So on your screen, when we talk about clinical application of all this science, these are the options what we have. The first one is the root canal revascularization via blood clotting. This is the concept which is widely used by all the clinicians across the globe. So this is a technique when first we need to identify the ideal case, which is having open apex or the immature apex. After having it, we need to do access opening, we need to do cleaning and shaping, and we have to make sure that proper antibacterial effect has been sustained with use of irrigation. Usually you use sodium hypochlorite, we use chlorhexidine 2%. We can also use triple antibiotic paste, double antibiotic paste to disinfect the root canal system. And following that, we take our endodontic files, go 1 to 2 mm beyond the apex, induce bleeding in the periapical area, and fill entire root canal system with this blood. And then place bioactive material such as MTA. PRF has also been tried with the same approach. The biggest advantage is that there is a very simple technique. It can be used with the currently available instruments without any extra expense. It is one of the most inexpensive method when we talk about biologic approaches in endodontic therapy. Regeneration is by patient's own blood cells. So there are no chances of any immune rejection. There is no chance of any pathogen transmission. And that's why this is highly successful treatment. So here is a case on your screen, what you can see. This is a mandibular premolar, which is having open apex. And with this immature open apex tooth, we are doing access opening, we are doing cleaning and shaping, we are using sodium hypochlorite 5.25% and disinfecting entire root canal system. Following that, we are taking 15 number K file, going beyond the apex 1 to 2 mm, inducing bleeding, and filling the entire root canal with it. After that, we have placed MTA in the conal third. And at the pulp chamber, we have done good composite restoration. On the screen, as you can see, over a period of time, 12 months, 7 months, 24 months. Eventually, from 7 months to 12 months to 24 months, you can achieve complete root end closure with elimination of the patient's symptom, elimination of the periapical radiolucency. There are a few more cases on your screen, what you can see. So the first case is type 1, where we are having increased dentin wall thickness at the root end. It is not important that always the root end length increases. Sometimes the root end width can also increase with the biologically based procedures. There is again another premolar. Same approach has been taken. And after placement of this material, there is increase in the root end thickness. Type 2 is insignificant continued root development. So as you can see, the root canal has been obliterated. There's again another premolar. As you know, premolars and central incisors are the most common teeth which undergo trauma or caries when the root end is incomplete. The majority of the cases when we are doing, they will be either in central incisors or they will be in the premolars. Another case, which is type 3, where you can see root end development without apical closure. In this particular case, if you can see on the left side of your screen, we have done good root canal access opening, revascularization has been done, coronal restoration has been placed, even coronal restoration with composite is done. But the root end has not been closed. Root end development has been continued. That is dentin-like tissue which has been deposited, but still it is having immature apex. And type 4 is complete obliteration of the root canal, where you can see the canal becomes completely calcified. Even if you take CBCT, you cannot see traces of the root canal. The next one is the mineralized tissue barrier between MTA cervical plug and the radicular plug. And this makes your treatment much more difficult because if any further reinfection occurs in this type of case, it will make it difficult to reach to the periapical area to achieve good disinfection. So there are few major disadvantages with this method. The first major disadvantage, if I have to highlight, is called conal discoloration. It is due to the minocycline. It can be due to the MTA as well. Even if, as a clinician, when we are using white MTA, it can also lead to the discoloration of the pulp chamber. So after 2 to 4 years of the treatment, the discoloration will be evident on the outer side. Apart from that, there is additional enlargement of the apical region is seen in the mature teeth. In older individuals, there are lesser stem cells, so the final outcome is always unpredictable, and canal can also get calcified with this approach. Another thing, when I say that we have to disinfect the canal, that means we are using chemicals inside the canal, which are chlorhexidine, sodium hypochlorite, and sometimes we are using EDT as well. And as you can see on your screen and read it out, irrigants can also affect survival of human stem cells. So right now in this technique, we are dependent on the SCAP, which is stem cell from apical papilla. And your irrigating solution, which are having antimicrobial property, can also damage and kill these human stem cells. And that's why the success rate is slightly unpredictable. So you have to make sure that our irrigating solutions are not extruding beyond the apex. We are using either negative pressure continuously, and we are using justified amount of irrigating solution at justified concentration. Because a solution which can save the tooth can also kill stem cells. And we have to make sure that doesn't happen. Clinically, only this method has been applied and it is used widely. All of the methods that now I'm going to show you in next 2 to 5 minutes are more of a theoretical. Few cases have been tried, but they are not FDA approved. Postnatal stem cell therapy is the simplest method to administer the cell of the appropriate regenerative potential. They've been injected into the disinfected root canal system, but the major obstacle is identification, which are the stem cells which are capable of differentiating into the diverse cell population. So technical obstacles include development of the methods for harvesting and any necessary ex vivo method which are required to purify the cell number, which can sufficiently lead to the regenerative endodontic application. One possible approach would be to use dental pulse stem cells, which are derived from the autologous patient's own cells that have been taken from the mucosal biopsy, and we can use them. But the disadvantage is that there is low survival rate. Second, the cells might migrate to the different location of the body. So it is not highly successful. There is a stem cell therapy which is quick, easy to deliver, but at the same time, low cell survival rate and high chance of complication. And as a clinician, our first goal is to do no harm. If we can't do good to a patient, at least we shouldn't be harming them. Till the day this method is proven ex vivo, we cannot start delivering this to our patients. Another method is called pulp implantation. So in theory, two-dimensional cell structures are taken and we are making them three-dimensional. And pulp cells can be grown on biodegradable membrane filters. And then we have to roll them together to create a three-dimensional pulp tissue, which has to be disinfected and then implanted into already disinfected root canal system. The first study was scheduled in 2006, and even in 2023, we are struggling to apply this into dentistry because the cells do not adhere properly to the root canal walls. Only the apical portion of the root canal would receive them. And the feelers which are being used are extremely fragile, so we are not using it. Another method is scaffold implantation. It's again of a theoretical use where dentin chips are being used, but they are not of much use. As I already mentioned, the natural scaffold and the synthetic scaffold. So for this, synthetic materials like PLA, PG, and PCL are being used. But what we still prefer are the natural one like collagen, glycosaminoglycan. But they must be engineered properly to fit the root canal precisely, and they have low survival rate after implantation, even in ex vivo studies. Another method is injectable scaffold delivery. So in a root canal, a tissue engineer pulp is not required to provide structure support to the tooth. This will allow tissue engineering pulp tissue to administer in three-dimension scaffold, but is it really possible? Is it actually clinically applicable? The answer is yes, and the answer is no. We can deliver good bioactive materials for that, but the hydrogels have not been delivered properly. What you can see on your screen is a schematic diagram that how injectable hydrogel can be placed inside. It can slightly regenerate and motivate this dental stem cells to proliferate further and give apical closure, but it is not always as easy as it seems in the diagram. This is still on a conceptual level. Clinically, making hydrogel is slightly more difficult. At the same time, the limited control over tissue formation, which we have seen. The cell survival rate is very low when we compare to the revascularization. So it is still in early stage to apply in patient's mouth. Another approach with the tech development is three-dimensional cell printing. So in theory, inkjet-like device is used to dispose layers of cells suspended in a hydrogel to recreate the structure of the tooth pulp tissue. The ideal positioning of the cell in tissue engineering construct would include placing odontoblastoid cell around the periphery, and with fibroblast supporting a network of the vascular and nerve cells. Though multiple cell type can be precisely positioned, but this is in very early stage. It is still on a developmental level. We are not using it in vivo right now. Gene therapy is again very interesting. A human cell contains 1 million strands of DNA, which contain 3 billion base pair, with sole exception of non-nucleated cells, such as the red blood cells. The DNA contains genetic sequences that control the cell activity and function. Now, there are various vectors being used, but what we always want to say that this is not approved by FDA, and it is very important to know about history as well. FDA had approved gene therapy in United States, but it was withdrawn in year 2003 because it was found that this therapy had developed tumors in different part of the body of 9-year-old patient. And that's how risky biologically advanced procedures can be if they are carried out without proper trials. For any study, first it has to be studied ex vivo. After laboratory studies, we have to go to the animal study, and then we can start using it in patient's mouth. The long-term follow-up is also very important from the clinical perspective. And that's why gene therapy is something which we are not supporting, as FDA has completely banned it now. Now, how we can measure the clinical outcome? To measure the clinical outcome, as a clinician, we are usually dependent only on the CBCT or the conventional radiographs. We have to look at the resolution of the periapical radiolucency, absence of patient symptoms, increasing the root and length, and the root wall thickness. These are the only things on which we are relying. Extended use of stem cells is also being done, but as I mentioned, we are just focusing on the revascularization right now. So on your screen, what you can see on the left-hand side is a 2D image. As you can see, it's a central incisor having immature apex. The second one is a 3D image or a CBCT, where we can see the exit root positioning and the thickness. Following that, we are having the coronal view and the sagittal view, so we can actually check what is the mesodistal width of the root in the apical area. Following this, we are doing our revascularization approach. And as you can see on the screen, this one is the immediate post-operative radiograph. Sometimes we are pushing our bioactive material even up to the middle third. Coronal third, middle third, and apical third, we try to fill coronal third with the MTA. Sometimes we push it even up to the middle third, but it should never be there into the apical third because it is important for the stem cell survival. Stem cell proliferation will take place, and that will eventually lead to the root enclosure. And you can see after 1 month, not much difference what we can see, but after 6 months, a definite difference what we can see in the root and length and the width. At the same time, we are dealing with the nature. And as humans, we have to be dependent on the nature. And there are many articles which are also stating unpredictability of the nature. What you can see on your screen is that even after regenerative treatment, even after biology-based approach in endodontics, case can fail. And it is important to identify why a case can fail, because it is all about disinfection and the disinfection protocol. If we are using and reusing our endodontic files, it can lead to reinfection of the root canal system. If we are not doing our basics of endodontic treatment, which is cleaning and shaping, it can lead to failure. If, as a clinician, we fail to identify extra canals in a premolar, And without cleaning those extra canal, without cleansing those microbiology or that those microorganisms, that byproducts, it will lead to failure eventually. There are many challenges with this approach. The replaced pulp may also become susceptible to the further pulpal disease, and it can also require retreatment in future. And hence, microbiological control method require for adequate tissue regeneration. The current culture condition and the nature of the microenvironment in which the primitive pluripotent pulp cells are maintained and expanded, it limits the success rate. So more work has to be done on the scaffold side as well. More complex root anatomy we are dealing with, the more complex outcome it will be. A way has to be found to ensure that this transformation of the growth will not continue beyond the control when implanted. Sometimes the tissues and cells can get differentiated beyond control, and that becomes a major issue. Matching the aging of the implanted tissue engineered part with that of the surrounding tissue is still controversial. We should always tell our patient about the potential of discoloration of the teeth as well when we're dealing with the anterior teeth. It is one of the most exciting development in dentistry today, for sure, but at the same time, it comes with its own precautions. This development of regeneration of a functional pulp dentin complex have a promising impact on efforts to retain the natural dentition and ultimate goal of the endodontic treatment, which is retention of the natural dentition. That is my book on guided endodontics. This is the most prestigious institute in India where I lecture. That is called AIMS Dental College in Delhi. I've been training postgraduates, clinicians, and teachers across the country and now across the globe. Thank you for having me over here.